So good morning and good afternoon, everyone. My name is David Terry, and I am a project coordinator for the Mountain Plains Mental Health Technology Transfer Center. I'm pleased to welcome you to the final session of our Improving Behavioral Health Service Access for Farming and Rural Communities series. Today's presentation is being provided by the Mountain Plains MHTTC and Great Lakes MHTTC in partnership with the American Psychological Association. Today's presentation is provided free of charge by the Mountain Plains Mental Health Technology Transfer Center and the Great Lakes Mental Health Technology Transfer Center. Today's presentation is available in the public domain and should not be distributed for a fee without the express written permission of the Mountain Plains and Great Lakes MHTTCs. The views and opinions expressed during today's presentation are those of our presenters and panelists and do not reflect the official position of the Department of Health and Human Services or SAMHSA. No official support or endorsement of DHHS or SAMHSA is intended or should be inferred. Please contact us with any questions you may have. The Technology Transfer Center Network is a national network of training and technical assistance centers serving the needs of mental health, substance use, and prevention providers. Today's training is presented by the Mountain Plains MHTTC and Great Lakes MHTTCs, and you can see the states and region that we serve. I will now turn things over to Luana Boslow with the APA for an introduction for our session.
Hi, everyone. Welcome to today's webinar on co-occurring mental health and substance use disorders in rural and farming communities. I'm with the American Psychological Association, as David shared, and I'm joined today by Thomasine Heitkamp from the Mental Health Technology Transfer Center in the Mountain Plains region. Next slide, please. APA is really excited to be partnering with the MHTTC networks to provide this joint webinar series. Over the past year, the APA staff have been discussing how we can work together with the agricultural community to address the behavioral and mental health needs of farmers and how together we can increase awareness among key influential audiences to get more support to the agricultural community. Today's presentation is a follow-up to an earlier webinar about co-occurring mental health and substance use disorders in farming and rural communities. Dr. Rebecca Roller and Dr. Maridee Shogren will talk about approaching and treating co-occurring mental and substance use disorders in the farming and rural communities. This follow-up session will provide additional information for using assessment tools to screen for co-occurring disorders in farming and rural populations. And our presenters will examine the unique ethical considerations considered or created by providing care in small communities. And they'll also touch on ways to identify and prevent provider compassion fatigue. We hope today's webinar will inspire attendees to work with this population that is so central to sustaining our country. Next slide, please. I would like to introduce today's panelists. Rebecca Roller is a psychologist. Dr. Roller is a licensed clinical psychologist and marriage and family therapist in Missouri. And although she is retired from full-time practice, she continues to be involved in the field of rural substance abuse. She serves on the board of directors for Restoring Hope Against Addiction, a local not-for-profit organization working in conjunction with Recovery Court. Dr. Roller is an owner and operator of Back 40 Bison, a conservation-focused bison ranch hosting for herds of North American bison. Next slide. Dr. Shogren is a clinical associate professor at the University of North Dakota. Her background in agriculture includes her upbringing in a farm family in rural northwestern Minnesota. Dr. Shogren serves as a content expert for the Mountain Plains Mental Health Technology Transfer Center on farm stress, interpersonal practice, and women's health. And now I would like to turn it over to our presenters. Thank you.
Hi, everyone. I am Maridee, and I am absolutely delighted to be spending some time with you today. In our previous session, Dr. Roller and I had an opportunity to spend some time really delving into rural culture and rural communities. And that is a recording that is available to all of you. And I believe David will have that link in the chat box for you so that you can see that. But as a little bit of a recap, for those of you who maybe weren't able to join us last time, Dr. Roller and I included a couple slides to give you a little bit of some of our background and where we grew up. So this is my slide. The picture on your left happens to be my maternal grandmother's farm that is now where my brother and is raising his family. I grew up in very northwest Minnesota, kind of on the North Dakota, Canada borders. So very small town tucked up in there. Most of the agriculture in our community are row crops, or looking at sugar beets, wheat, corn, sunflowers, that type of product. And we have been experiencing a lot of stress up in our area in Minnesota, North Dakota. We're having, again, another very wet summer. The upper right picture happens to be one of my brother's soybean fields from last fall. So they ended what looked to have been a very beautiful growing season with just torrential rains. And actually, this is a soybean field that was never able to be fully harvested. The bottom right picture, unfortunately, is a view from one of our wheat crops this year. This was just in June. They have had well over 10 inches of rain in areas up in northwestern Minnesota, and we're expecting more again tomorrow. And unfortunately, this was a beautiful wheat crop that has eroded with 6-foot crevets right into the field. So very much experiencing some farm stress up in our area. And then I will turn this over to Rebecca to share a little bit with you.
Good morning from Southwest Missouri. I'm very honored to be a part of the presentation today. In regard to my background, I came from a very rural area, Southwest Missouri. The town I live in right now has a population of 224 people, so it's actually considered a village. I never participated in agriculture though until about 2012, when my husband and I started to raise bison. And over the time, we've had a great time understanding a little bit more about farming, what that means, integrating with the community. And honestly, that bottom picture of us and of me next to the working system probably gave me more credibility than anything else that I could have done in regard to connecting with farmers. So happy to be here today and just share some of the experiences that I've had serving in a very underserved area in this part of the country. Next slide. I think I'm starting today. Some of this may be a little bit of a repeat from the previous session, but we felt like we need a little introduction to the topic. One of the things that once the referral is made to a provider is that we need to engage with that particular individual. And so I would say that probably therapeutic alliance is absolutely the most important thing that you can have in regard to getting someone to not only be in therapy, but to maintain attendance in therapy. So understanding that as rural areas are not homogeneous, neither are farmers. Everyone that presents is a different opportunity, a different story. And understanding also the concept that's been covered in previous sessions called the agrarian imperative by Michael Roseman, where we need to understand the very importance of farming to farmers, that it's not just a way of life, it's who they are as a person, and it's almost embedded in their DNA. And so being able to understand the importance of what they bring to us in a therapy session. And then I can't emphasize enough in regard to engaging with farmers and getting them comfortable, those very basic things that Carl Roger taught us long ago, of being engaged, having unconditional positive regard and empathy, and making sure the client is actually feeling those things. So once someone decides to make an appointment and come in, it's very, very important that we establish that therapeutic alliance as quickly as possible in the process. Next slide. This is kind of a visual of how things usually present when someone comes to therapy, especially in a rural area where there may be a lot of different things going on. And so our job is sort of to assess all the things that are presented during those first sessions and basically help come up with a treatment plan to be able to understand, especially with co-occurring disorders, what's going on. And what our job basically is, if you'll go to the next slide, is to take all those things that are presented and basically put some organization and structure to them so that we can go from that point on and provide good treatment for that particular client. I can't stress enough the importance of in developing that therapeutic alliance and determining what's going on. The clinical interview, we sometimes undervalue that, and a good diagnostic interview will be a conversation with that person to understand what's happening with them. And this is a great time to just listen to the story they bring to us, the narrative they bring, and try to put some structure to it so that we can help them. Next slide. One of the other things I use, because I have also been trained in family systems, and every single client that I have in their chart will have a genogram and then an echo map, which we'll look at a little bit later on. But a genogram is one of those types of assessments that gives us so much information. Again, a lot of times it's done just as a conversation. We look at going back, if we can, maybe 3 generations, and it's not just a family tree, but it's also the relationships that are there. You can look at, this is from a genogram software program, and if you go do an internet search on just about just using genogram software, you'll find several out there that may be available. But this one basically can show you, for example, if there's a broken relationship or a very, very tight relationship, or if there has been substance abuse in the family history that goes back for several generations. You can also look to see any types of mental health problems that might be there. If there has been a history of depression or anxiety, then we can look at that, and of course any other issues that may have somewhat of a genetic or certainly environmental implications. So genograms are things that I have in the chart, and I will take it out from time to time when certain things happen and just keep marking on it, documenting on it. And it also helps to just provide sources of strength for our client. I like to use a very collaborative, strengths-based approach and finding those things that are not wrong and maybe being able to utilize those in getting the client in a better shape. All right, next slide. The next thing I use a lot of, and these are old tools that have been out there for a long time, nothing very new, but they just have done very, very well with me in working in a rural area where I am interested in all the systems that are involved, not only just that may be causing problems, but again, that may be helping that particular person. So this is an example of one, and of course, these are things you can just jot down on paper. You don't have to have a software program, obviously, but I'm looking at a family in the center that may have presented. Maybe Sam is the identified patient there in the center, and his family is located next to him. And then the systems that surround that particular individual, the things they do, the places they go, the things they belong to, work. It could be as like a volunteer fire department, a church, extended family on either side. And it can also be maybe a resource. Maybe there is a source of income, like a farmer's market, for example, that could be a system that is a part of that person's life. And what we do is try to document, for example, if you look at work, it doesn't take a lot of, it doesn't put a lot of energy into the client, but it takes a lot out. In contrast to maybe the volunteer fire department that he may go to, that he doesn't have to do a lot with them. It doesn't really take a lot of energy, but it's very, very important to him. As opposed to maybe extended family, that might be there might be a lot of conflict in that. Maybe there's a lot of difference in regard to how to run the family farm. We see that a lot with younger farmers deciding that they want to do something different, and extended family or previous generations not understanding why. And then maybe, like an example, the wife's extended family, who maybe they don't really take any energy out of the family, but they're very supportive and they put some in it again. So you're looking at all the systems that may be there so that you can understand where the issues and problems or stressors really are, especially the important ones that may be contributing to a co-occurring disorder. And then you also find the strengths so that you can encourage that person to utilize those strengths in their recovery and their walk back to mental health. So, okay, next slide. So in regard to assessment, there are so many different assessment tools out there, and every therapist has a choice or a one that they prefer, or one that even matches their therapeutic approach a little better. But the ones that I have found particularly good in a rural area are the SASSY 4, I think, is the latest version. And again, you can do a search for these and find out all kinds of information and some data on their reliability and validity and so forth. But this is a screening tool, but it's a subtle screening tool. It's a little bit more lengthy than normal screening tools. but it's very helpful in finding, number one, is there a probability of a substance use disorder that's presenting when someone comes in for treatment? But it also has several scales that if you dig down into those scales and you look at what's happening inside those scales, they're also revealing things like defensiveness and things like the client's ability to acknowledge that substance use is having a problem with him. And they also have some new features such as a prescription drug scale as well. So it's fairly easy to score. There's a paper pencil version that has a template that you cover over, and it probably takes 15 minutes to score it by hand. And it provides quite a bit of information actually for that much effort. And then there's also online versions where you can get not only the scoring, but a narrative report written up as well if you want to pay for that. And then they also have an adolescent version, which comes in very handy because sometimes the presenting client is maybe an adolescent in the family or a child in the family, and sometimes there are substance abuse issues going on there as well. So the SASSY is one that I use quite frequently after there's already been, you know, an interview and knowledge that there's something going on, and if I need to find some different information or some deeper information. Okay, next slide. And then another one that's used, I use this a lot in recovery court, but it's the Addiction Severity Index. It's basically, in its first form, was a semi-structured interview. And so again, you're like having a little more detailed conversation, much like the diagnostic interview. But the ASI takes 7 different areas of a person's life and then asks questions and gets responses that help us to understand, like, for example, if substance abuse is having any issue in regard to medical status, or if it's having any impact on employment, drug use, alcohol use itself and what that entails, and if there's any legal issues, family issues, psychiatric or mental issues. And I really like this one because it's not dichotomous. It's not a yes or no or true or false answer. I usually will give them a little card or have a little card out where they can see it, and they will give me answers like, 0, not at all, or 3, pretty much considerably. And so we're having a conversation but putting some structure and some numbers to it so that we sort of have an idea on how things are impacting that. And if you are a fan of motivational interviewing, it's pretty nice to go back to this in regard to trying to determine how close they are to change and the impact something is having on them and getting them to move toward that. That's another topic altogether, but it works really well with further substance abuse treatment modalities. And then there's a computer administered one now, and then which I'm not familiar with, but I know that it exists. And the other thing that is interesting is a light version that can be a follow-up so that you can, again, track progress over time with this particular tool. And again, you can find it online, a lot of different information. I think may have been a link in a previous webinar about where to find out information on that. Okay, next slide. And then if you're going to diagnose a co-occurring disorder, one of the things you're going to be doing while you're doing the clinical interview is getting down to those symptoms that show up in our diagnostic manual, the DSM-5. And I bring up 2 things that I think are very important when we get ready to make a diagnosis, and that is understanding if that particular issue is actually causing clinically significant distress and impairment. It's one thing to say that someone is very upset, very stressed, and so forth, but there's a difference between that and actual clinical depression. And so making sure that we're referring back to our diagnostic manual, and that also whatever's going on is not more attributable to physiological effects of a substance or another medical condition. I did have a farmer one time that came in with high anxiety, heart palpitations, and my mantra is always rule out the physical first. And going back to the doctor, he found out he actually had a tachycardia problem. And so, yes, he was anxious about that, but there was another medical condition underneath that was attributing to it. And just knowing that is very important. And then also knowing if there are substances involved because of the connection between being depressed or feeling depressed and substance use, or even coming off of substances. If you want a more general assessment of personality, there are very common ones like the MCMI and the MMPI. I just mentioned the restructured form just because it's shorter. I don't know everybody else's experiences, but having someone sit for a huge number of questions is really difficult, especially if they're already under stress. So I try to keep the assessments long enough to help me to understand if I don't get a clarity on the diagnosis, but also short enough to actually have them finish it and treat it, I guess, seriously, because sometimes it's just so many questions. Then there are targeted ones for PTSD. For example, the VA has several options on PTSD scales or PTSD instruments, and they have civilian versions that I've used in the past for farmers because of the trauma that's associated with a lot of farm events. They have a lot of potentially traumatic events that over time can accumulate into full-blown PTSD. So sometimes it helps to have a civilian version of that. And then also instruments that cover anxiety and depression and being able to monitor progress with those that can be repeated over time. Okay, next slide. And then we have ethical considerations. You know, the number one is, and then the one that's the most difficult probably, especially when you're the only provider in a huge radius of geography, is practicing within your scope of competence, because you will have things that come across that, you know, I never was trained for that in school. That's not my area of competence. And so being able to either refer, or in some cases, when I absolutely could not get someone to go to another town, which because of many reasons, transportation being one of them, and the expert in that particular topic was, you know, quite a distance away. One time in particular, I worked with a medical doctor because I had someone present with some anorexia. That's not my competency at all. And she was not actually underweight at all at the time. And so I worked with a medical doctor. I worked with someone in Springfield nearby that knew that particular area. And we agreed that as long as that she maintained the weight that she needed to, she could still see me. But at some point when she went below that, she would absolutely be referred to someone else, and they would have to find a way to get her there because I would not see her. And those are really, really heartbreaking decisions, because the situations are never as simple as what you want, especially when someone is really dealing with a difficult issue. So knowing when to refer, and usually at the onset, as soon as you know it's an area that's not your expertise, I think being able to refer to someone, having a group of other therapists that you interact with that you know are competent in areas is very important as well. And then also there are times, especially with substance abuse, when medical supervision or detox is important. And so getting someone in as soon as you can and having supervision under that particular situation. And then also there are times when, you know, inpatient or in sessions in your office are not adequate enough for someone's issue, and they may need inpatient or residential rehab and basically doing that. So, okay, next slide. And then boundaries in our area, we have a phrase, good fences make good neighbors. And so in rural areas, it's really difficult to maintain boundaries because there are going to be some boundary crossings from time to time. Hopefully there are always crossings. In regard to boundaries in general, if your therapeutic approach is more like a psychodynamic where you want to be a blank slate, then you know, you're probably going to have a lot stronger boundaries. It's going to be really difficult to practice in a rural area. But I want to make a very important point. There's a difference between the crossing and the violation. Boundary crossings are normal, unavoidable, and sometimes expected. I'll explain a little bit more about that. It's those moments when you're doing an intentional boundary crossing. We'll talk about some things like multiple or dual relationships because you can't avoid it. And sometimes in an area that you're serving, then being involved in, for example, on a school board or another board of some kind, you're going to cross paths. It's very, very normal. But a violation, on the other hand, are none of those above. They're abnormal, they're avoidable, and they're absolutely unexpected. And a violation is something that really gets us into trouble. And actually, too many boundary crossings have a cumulative effect. So we really, working in a rural area, you really, really have to be aware of making good choices and wise choices and consulting with others to make good decisions in ethical situations, which I think ethics in general is about good decision-making, informed decision-making. Next slide. So two areas that are difficulty with boundaries, one is multiple or dual relationships. And there are three rules that I think are important for us to remember. Never should that multiple or dual relationship exploit a client. It should not harm a client, and it should not harm therapy or impair therapy. And so being very conscious of the things that you consider to be involved in. There are times whenever you are going to probably have to see, or you are not going to have any other choice, but maybe you'll find out after the fact that you are seeing the uncle of one of your clients. That happens from time to time. So, but trying to be as intentional and careful with that as possible. And then in regard to confidentiality and self-disclosure, I had a very, very good supervisor whenever I was in residency who told me that you need to set the rules for meeting these people up front when you do your all your limits of confidentiality and other things. In other words, he would say, have the conversation that says, we're going to be at the grocery store and you're going to see me. And so we're going to have to figure out what we're going to do because your confidentiality, I will not say hi unless you say hi first. And if you say hi first, I'll say hi back because that's what we do in small towns. This really is important because when I first set up practice in a very rural area, I had two situations that came up quite frequently. One is that someone would see me somewhere and they would be upset because I didn't even look at them, or I didn't say hi, or I didn't, come over and talk to them. And then there are the other situations where I'm in the grocery store and someone hides from me and so I'm going to approach them and say hi. So I think setting that up front, this is the way we do it in a small town. It's very, very important, even especially with children too, because that's going to be a really difficult situation. That's hard to control. So as far as disclosures go, intentional, helpful disclosures are probably important. It's not uncommon, for example, someone to come into therapy on a hot day like it is today in Missouri and say, oh man, how do the bison handle heat? And I'll probably answer that question because I think it's going to help the therapeutic alliance, but it'll probably stop there and instead of saying, well, they're really hot. So what do you do with your cattle with heat, and so understanding that those intentional, helpful disclosures are really always in benefit of the client. And that's important to be ethical in that. And then you have to compartmentalize information very carefully because, again, if you're seeing that uncle of that other girl, then they're going to probably say something that you're going to have information that you shouldn't have. And so I think being able to be very wise and compartmentalize the information so that it has no impact on the other person that you're seeing. And one thing I did in a rural area to avoid those things was I was a training site too for practicum students, and I had residents that would come in for experience in rural settings, and that was very, very helpful in being able to refer them to within my practice. Okay, next slide. And then this is probably a session in and of itself, but I do think it's important for us to understand that we have a growing diversity in rural America, and that what I have seen from my perspective is that that diversity tends to be in pockets of people who maybe come to an area for a job, like the Tyson chicken plants and things like that. And so understanding, first off, that, you have your own cultural worldview and understanding what it is, having more knowledge about the other cultures that exist. If you're in an area where you have a pocket of other diversity things, understanding and talking to other people involved in that to understand what you need to know to help provide good treatment. And then acknowledge your assumptions and biases with other cultures. For example, in some situations, having 3 or 4 family members would be, a therapist might look at that as an enmeshed family, but in some families, that's absolutely normal and part of their culture to involve other family members. And then being able to, once you get the knowledge, make some changes. One of the very difficult things that I had to do was work with a translator and knowing as simple as, who do I look at when the person's speaking? I look at the client or look at the translator, and being able to consult with some people who had experience with that so I could do it properly. And next slide. And this is my last one. Self-care, taking care of yourself is an ethical imperative so that you provide good treatment. When I started, I would literally work 12-hour days, and it got to a point where I knew I was tired. I knew I was not working as well as I should. And so understanding that if you're the only therapist in the area, and it's hard to say no, you will work yourself to death. So being careful to monitor your schedule. Also, there is an issue of vicarious traumatization that is very real. In my situation, we had some very difficult events that occurred that were very, very, they were terrifying in many ways. And I would have to process that with 5 or 6 people in the course of a week who had interacted with that particular event. So processing a death or a shooting or whatever multiple times can become very, very difficult. And understanding that burnout is probably not the only issue that you're going to have. You're going to also have a loss of engagement. And I think that's the saddest one right there, is that's where we learn how to sort of disengage in things. And so being careful to monitor the level of stress that you're experiencing and avoid burnout, but also the loss of engagement would be important. And part of that is that self-awareness and intervention. And having people surrounding you that you can interact with that can also tell you you need a break. That's important. So, okay, and with that, I'm going to turn this over to Maridee, who's going to talk about compassion fatigue.
Sure. Thank you so much, Rebecca. And truly, everything Rebecca has shared today just resonates with all of us who have worked in rural settings, and such a nice lead into talking a little bit more about the compassion fatigue that we often do feel. Now, we certainly understand that this isn't isolated to just rural providers, but we do know that there are some unique circumstances that rural providers might be experiencing. So farm stress is heavy. It's a very difficult thing for providers, not only behavioral health providers, but those of us who work in primary care to not only experience but to treat. And some of the unique factors that are there that lead to this compassion fatigue, or things that you might identify in yourself as having compassion fatigue, would just be that simple physical and emotional exhaustion that we sometimes can experience because of and during our care of others and service to others. Consequences of this can lead us to just getting into that apathetic mode where we're losing interest in what we're doing, that fatigue that's just so overwhelming, and feeling trapped, like we just can't make progress. We feel that we're not doing a good job and we're being ineffective in the care that we're providing. And as Rebecca mentioned, when we're working with maybe several members of a community who have experienced similar circumstances, and then that's brought into us, and it's talked about, that we can actually experience those that feeling of being traumatized because we're kind of going through that same experience with these clients. Next slide, please. The added impact of farm stress really comes back to what we've often talked about as this goldfish effect, that we've got sometimes smaller communities. We kind of are living in a very sparse type of an area. However, our neighbors are all knowing what's happening to us. They're seeing us, they're looking at us in that goldfish bowl, if you will. So then as we reach out and we've got people trying to engage in counseling and looking at treatment for their co-occurring disorders, that impact of feeling that weight of everybody kind of knowing what's going on might actually increase this compassion fatigue that we're seeing ourselves experience. So providers may be members of the farming community as well. Maybe if you are that behavioral health provider, maybe your spouse or your partner happens to be a farmer in that community, or maybe you have a dual role and you also farm. Perhaps your children play with your clients' children, or you have mutual friends or colleagues. Situations can be very, very similar across that board. But one thing that is often greatly experienced, especially in these smaller rural communities, is this collective stress. So for example, up in northwestern Minnesota right now, everybody is just down. Having all of these torrential rains coming through, the hail damage that's there, the entire community is feeling that. And if farmers start to feel strapped, for example, maybe they're like, it's not going to be a good season. We might not be able to fully harvest. I don't have extra cash to spend. That trickles down to the local cafe. Maybe everybody's not getting together for breakfast. They're not having dinner together, talking about what's going on, having just that social interaction. Maybe families choose not to spend the money to engage their kids into those rural softball activities or sports that are going on in the community. Then we've got the people that would provide those services feeling that effect. So it really can affect that entire community depending on the type of farm stress that's being experienced. And next slide. So as you all do consider some self-care and really doing that check-in to see how you are feeling, could you be experiencing compassion fatigue? One tool that has been shared with us by a colleague in our TTC network, who I happen to have the opportunity to work with in an integrated care setting in a federally qualified community health center, is a tool called the Professional Quality of Life tool. And this is one that she often said, hey, have you checked in? Have you done a little self-assessment to see where you're sitting at with things? It is self-administered, it's very brief, and it is free. I'm looking at the version 5 right now, and it's about 30 questions, very easy questions that are ranked and numbered, and then you score, and you kind of get an idea of how you're feeling. So it rates you on your compassion fatigue as well as your compassion satisfaction. And it may help just be that push that we need to reach out for assistance if we need to do so. So that link is here for you. I did just recently visit this site, and I was thrilled to see that they have now also included a pocket card for COVID-19 crisis, and really specifically looking at the stress that we're seeing, the added stress that we're seeing because of the pandemic. Next slide. So just in summary, we wanted to just remind everybody that farm stress really is just not a farm problem. All of us as providers, families, communities, and policymakers do need to work together so that we can address that ongoing impact of farm stress in our region and in our nation. And next slide. Finally, we did want to remind you that at the end of the slide deck, we do have a very extensive list of resources for you, websites to visit that cover the information that we provided in our last session as well as today. And then this is a toolkit that has been developed through our Mountain Plains Mental Health and Addiction Technology Transfer Centers. This is hyperlinked when you do get the slide deck, and it's a free resource for you. It is ideal if you are working with new providers in rural communities, and it highlights alcohol use disorder and depression through the view of a farm family, a young farm family, a multi-generational farm family. And so those of you who like to learn through a case study, it's a great tool for you to look at. Next slide. Okay, so this brings us to a nice amount of time to share with you and answer questions that you may have.
Thanks, everyone. My name is Thomasine Heitkamp, and I am the co-director and PI for the Mental Health Technology Transfer Center. And I appreciate doing this work with a colleague at Great Lakes Mental Health Technology Transfer Center and the American Psychological Association. Thanks so much, Maridee and Becky, for this great presentation and wrapping it up with some really good and important skills and assessments. So there are some questions in the chat box, and while we have Maridee presenting, I know her passion for women's health because I have the pleasure of working with her daily. There is a question about, do men respond to stress different than women?
Yes, they do. And in fact, we really encourage you to view our previous recording where we did talk about that a little bit. And what we know is that women tend to be very supportive if they have a male partner, a male spouse that's in that farming community. And that male partner may try to be very supportive as well, but women just experience that stress differently. And it seems to be, based on the literature that we have, that she may not have as much comfort displayed toward her for that stress. I think in addition, what often happens, if we look at a very traditional sense of a farm family, if the male partner or the spouse is the primary farmer, women often find themselves holding down not only the work that they do on that farm, but holding a secondary job, sometimes for health insurance, for example, and they may still remain the primary caregiver of the children that they have. So then we throw into that mix that added stress, that added juggle of juggling the family, the kids, helping out at the farm, maybe doing the books, holding the responsibility for health insurance to bring in that extra income. So I do think that the literature supports that, and we do see a very different kind of stress in women.
Thanks. Rebecca, would you want to add anything from your clinical practice?
I agree. I think that men have a tendency to compartmentalize things, and so they're able to sort of say, this is work, this is home, this is whatever. On one hand, that's good, but on the other hand, it also causes them to dwell and to focus. And women are more, I think, systemic thinkers, and they're balancing a lot of things at once. But I think it's also harder for men culturally to acknowledge stress, especially in a rural area, because I should be able to do this.
Yes, I would agree. And, you know, from the primary care perspective, women, if we get one opportunity to come in for healthcare, it's for that annual exam. And I can't tell you how much of that visit is often spent talking about the stresses that she's experiencing, because she feels like she gets one shot to come in and talk with a provider. So we do way more than that women's health exam.
Thanks. Becky, I'll toss this one to you. Do you do anything that's specific in your assessment to look at the unique issues of rural families, rural farm families in particular? Is there any tool, or what kinds of ways do you adapt existing tools to explore the issues of farm stress?
I'm not aware of, and there very well could be, but I'm not aware of any validated tools, assessment tools specifically to address farm stress. I think, again, going back to the interview and finding out what is going on, listening to, you know, their story, their narrative, you can do a lot of assessment through that to find out, you know, what are basically common things going on. Inside a family, for example, there's going to be some things that happen in all families, regardless of whether it's the stress of a farm or anything else. So, you know, some of those things still apply. Farm is just the trigger. It's complicated whenever it is a family farm that crosses generations, though. And I think that at that point, it becomes almost a financial issue, a management issue, all those things in addition to a mental health issue. But so I try to focus still on what we can control within that person's domain. Better.
So I'm gonna toss this question to Maridee with a little different twist, because I know the product that she just shared with you has a number of assessment instruments in the case scenario. So if you want to speak a little bit about John, the man in the case scenario, and how you use that assessment instrument, a variety of instruments to get at the core of the problem.
Sure. So the product that we're referring to is really kind of all the pre-work that is often done in the primary care setting before we're able to refer to our colleagues like Rebecca for that additional assessment and evaluation. So when we look at John, he's a young multi-generational farmer who very classically presented to a primary care setting with symptoms of stress that he didn't realize were stress. Heartburn, high blood pressure, that, you know, people come in not thinking that it's related to the stress they're experiencing, but something that we can fix with the pill, or let's take care of that physical ailment right away. And through the discussion with John, two of the classic primary care types of screening tools that we use would be one, we use the ESPER technique, for example, to look at alcohol use disorder. So in this particular case, we looked at the audit screening tool. There's an audit C and there's an audit to look at any type of risky alcohol use that might be there. And that was accompanied by PHQ-2 and 9 so that we could get information, basic information about the possibility of depression symptoms. Ultimately, as the case unfolds, we learned that John does have enough of the criteria to meet the diagnosis of having an alcohol use disorder and strongly suspect a major depressive episode. And so we talk a little bit about how that we work interprofessionally to get that referral in the right places, but sadly how often in rural areas, and Rebecca alluded to this, we might not have those specialists right in that community. So how do we get our clients to the added resources that we need?
Thanks, Maridee, really appreciate this. One of the other questions we're seeing in the chat box, and I think it's a really good question for both of you, given your farm backgrounds and your rural nature, is looking at some of the stressors in the community and ways that we can respond to, it isn't just a family stress, it isn't just a farmer stress, but working within communities, that larger system response. So which one of you would like to take this? I know you both know a little bit about this. Go ahead, Becky.
Well, I guess it depends upon the stressor what might be a good thing to do. You know, we had a stress at one point in our area that had to do with meth use. We were like a #1 county in the state of Missouri, which was a #1 state, and it was terrible. I mean, they had to eventually stop arresting people during one of the raids because DFS, the Division of Family Services in our area, did not have enough homes to put the children in. And it was actually somewhat traumatic for the entire community. And finding ways to educate. I know in our office, we did some trainings for foster parents and things like that. And, you know, trying to sort of just help provide education where we could and put people together with resources that were available. You know, so I think that having a community response to something like that involves the entire community and establishing good relationships and then practical services.
Yeah, I think that's awesome. And I think what I would add to that is always remembering for those of us who happen to move out of our small town communities. And so, you know, I moved to the big city about an hour away from where I grew up. This is where I live right now. But it's really important to go back to support our local communities. And so, you know, when we can come back and, you know, feed some financial resources into those communities, talk to people. There's nothing more heartwarming than going back to a church service where everybody remembers you from where you were little, but you can see how they are doing and providing that support when you go back, sharing that education. Everybody's interested in and means so well about what you're doing. But stay connected to these communities so that they know that they're being remembered and that they are being supported.
And Deborah raised a really good point about workforce shortages in rural areas. We've been talking about that throughout the series in terms of people being expected to travel up to an hour, even longer for services and long wait lists and those types of issues. We did offer last week a session on telehealth where we do address some of those issues of access to care using technology, but I'm wondering if either one of you would like to talk about the travel involved in receiving care and some of the workforce issues in rural community. And this is someone from rural Nevada.
Sure. I think I kick it off. In our previous discussion, we did talk about health professional shortage areas and how significant they are, not only in mental health arenas, but in primary care arenas. And so, you know, sometimes what we have to do is think outside of the box and make people aware that there are often opportunities to practice in smaller communities. And HRSA offers some grants that grants or funding to go back for scholarships, for payback, if you will come and work in some of these smaller communities. And so for newer providers, that might be an option for some of that tuition payback to just go back and live in those communities and provide some of that rural care. Rebecca, any?
Yeah, my practice was actually certified as a health service core site. And so we could offer loan repayment to anyone who wanted to come in and practice. And that was very helpful. And students, I actually taught at a university in Springfield. And as part of that, I was able to connect with some students who wanted rural experience. And so we were able to, you know, have them come down. But honestly, it was an hour's drive for them to come to the office. So I made it very well worth their while. They got some free lunches and some things but they also had enormous amount of experience in the rural, in addressing rural issues and needs and working in conjunction with other like primary care physicians and things. So part of it is marketing rural areas. We don't market rural areas in society. We portray them as, you know, backwoods kind of places. And I'm telling you, there's some very smart people who live in these areas and learning to appreciate that. So
agree. And when Rebecca mentioned lunches, you aren't going to find any better cooks when you get into these rural areas.
Yeah.
So here's another question that I know both of you are certainly aware of is the seasonal impact of stress. And so, Maridee, maybe talk a little bit about when the sun is shining impact.
When we were putting this co-occurring product together, that takes me right back to, I spend a lot of time talking with my family members who are farmers and asking kind of those questions. And when the sun is shining, at least from the primary care world, farmers have work to do and they often miss appointments. And that's something that you have to make an adjustment for in rural care, that sometimes seasonal means they are working really, really hard at that point. On the flip side, if you get torrential rain, that might be the time that they're calling to say, hey, can I get in today to have this heartburn checked or what's there? And so rural providers sometimes have to make those accommodations. Rebecca had shared a great story about, you know, a farmer coming in and still had manure on their boots. Yep, that happens. So we have to be accommodating to do that. But the other thing I'll add, in a quote by a family member, who had said that, you know, when it's raining, that's when it's really hard. That's when the dark thoughts come in, and that's when it's hard to think about how to keep going in that instance. And I'm not talking about that lovely rain that comes just when it's needed. I'm talking about those significant weather changes that lead to that extraordinary stress that farmers do experience.
Anything more you'd add, Rebecca, on that?
No, I mean, it's making yourself available is one of those things that you do have to use some self-care a little bit, because if your heart's there, you're going to make that appointment. But the introduction of telehealth has been a game changer for me.
One of our first presenters talks about seeing her patients, clients, after they're done milking cows. And you know, some of the stressors of the livestock world we're in. I don't know if either one of you, there is a question about that in terms of the stress on farmers when they don't feel their product has value.
Oh yeah, and I think that one thing we need to just be thinking more and more about is just thinking out of the box with farmers. We've gone down this road for so long, and there are so many new ways to do things. But when you are depressed and when you are anxious, it's really difficult to open up your brain to think flexibly about what are some other alternatives. So communicating when someone has a great idea is very, very important, I think, just to help them.
Absolutely. There's another question about interpersonal violence and some of the isolation and the impact of COVID and concerns about that isolation. And any thoughts about some preliminary data? I know we have anecdotal data that people are more isolated and there's more fears, but anything you'd like to say? And I think this will probably be our last question related to interpersonal violence that might be specific to needs in farming and rural communities.
Well, I can speak to that because I think farm or rural families in general are more of what we in family systems call closed systems. And so the important thing is to somehow have an entry into that system, you know, so that you can see what's going on. And so, you know, that's a huge issue in rural areas. And obviously, if you've got a primary care physician or nurse or someone who has the ability to establish a connection somewhere, you can maybe break into that system a little bit. But there's a tendency to shut down, close down the system, not let information in or out. And that's a tough nut to break, to crack.
That's a really great point. And that focus of the product that Maridee's talking about, where oftentimes you learn about the depression in the male farmer through the wife. You learn about it through the family practice physician. People don't present with an issue of depression, they present with something else that's related to stress. That requires that you dig a little deeper. So, all right, the risk of one last question. One of the questions earlier in the Q&A box was, how do you know that people are telling you the truth when you're doing these assessments?
Right, I don't know if I can answer that one. For me, I think one of the techniques that I will use is if there's a question that comes through that I'm not sure, or maybe I think there's a little bit more, it's all about eye contact and figuring out how to change that question, asking it a little bit different manner. For me, sometimes in women's health, it's okay, let me step out of the room for a little bit, and when I come back in, we start the question a little bit different way. Rebecca, anything else?
No, for me, it's kind of a simple thing in a way, is asking less yes and no and more open-ended questions, you know, and saying, can you tell me a little more about that? You know, yeah. and just doing those kind of probing questions. And you have to earn the right in some ways to get the truth.
Yeah, and I think we have to also, if I could add, be open to the final question that usually happens as we're walking out the door, at least in primary care. Is there anything else I can do for you? And
yeah.
Address that if you ask the question.
Doorknob questions.
It never hurts to start assessing the nature of the crops, which what Maridee was just talking about her wheat fields. So thank you so much to everyone who joined us, and thanks for all those really positive comments coming up in the chat box. It has been our absolute pleasure to host this event and work with American Psychological Association as a mental health technology transfer center network. Each of these sessions has slides on our webpage that you have access to. We put the recordings up so you have access to the recordings. So if you have some colleagues who wanted to attend, grab the recording and have them listen to it. And these resources are all very, very helpful and will provide you with supports that you need as you're addressing some of the rural and farm issues. And we know farm stress is really pretty significant for a variety of economic and weather and COVID-19 and production. So there's a lot going on in these rural communities that it's really critical that the therapist, the provider, understand those unique natures. And I really appreciate all of you that presented in this series. I enjoyed listening and always learn.
I just want to thank everyone. This has been terrific. And I've really enjoyed this series. And I hope we can continue. APA is very committed to helping the agricultural community. And we're actively talking about what else we can do beyond this webinar series. And I hope we can work again with the MHTTC network. Thank you.
We're in. Thanks, Luana. Appreciate it. Take care, everyone, and thanks for joining us today.